तो जब शुरू फजल कर दे तो मैं शुरू कर दूं ना, ठीक ठीक।
अभी टाइम है वैसे भाई, टाइम है अभी 1
सर हम इंतजार में बैठे हुए, 8:15 था।
8:14 हुए अभी प्रिसाइज।
अच्छा चलो, गिव अ फ्यू मोर मिनट्स।
So, Assalamu alaikum.
वालेकुम अस्सलाम।
I welcome you all to the today's grand round. So today's our speaker is Professor Dr. Mohammad Wasay. He is an excellent teacher, recognized researcher, and a very well known speaker. So today he will talk about the neurological burden of COVID disease. It is pathophysiological mechanism involved in it, the neuroimaging of the neurological symptoms, and the complication of it. So with this, I want more time. So I invite Dr. Mohammad Wasay for his speech. Dr. Mohammad Wasay.
Bismillahirrahmanirrahim. Thank you, Fazal. It's a pleasure to discuss neurological involvement in COVID-19. It's not a lot of people know that the neurological system is one of the most affected systems in the COVID-19 infections. But hopefully, this session today, I think, will be a very informative for a lot of medicine trainees and residents, that how it affects the nervous system and what's the spectrum of neurological involvement in this infection. And hopefully, we will be looking at more and more of these symptoms in future patients in our patient population. So it's pretty well known, corona infections. Actually, for the last 60 years, we have known these coronaviruses. The first one, it was isolated in 1962. Most of our experience related to this corona infection is two epidemics. And I'll briefly discuss that what were the neurological findings and neurological involvement in those epidemics, which translated this information that, this COVID infection has a lot of similarities with those neurological involvement in previous two epidemics. The first epidemic was in 2002 and 3, and that is called SARS-CoV-1. Most of these patients were in China, and there were 8,000 affected patients reported. Mortality was 9.6% in that specific epidemic, and origin was supposed to be or considered to be bad. So that was first epidemic, which is about 20 years ago. And the second epidemic was in 2012, which is called MERS-CoV-1, which is Middle Eastern virus. Most of these cases were in Saudi Arabia. There were some in other parts of the Middle East. And altogether, there were about 2,500 cases reported. This epidemic has a high mortality, 34% mortality related to this kind of corona infection. And the host was again bats and camels. So these are the two epidemics. And the neurological involvement was pretty well known in these two epidemics. Before we go to the neurological involvement, just brief about what is this coronavirus and how it affects the whole body, especially the nervous system. So it's a member of the coronavirus family, which is a RNA virus. Basically, what it does, it uses angiotensin converting enzyme 2 receptor as a receptor to infect the human body. So wherever you have ACE2 receptors, those ACE2 receptors are affected by this virus, and the symptoms come along with the involvement of those ACE2 receptors. Now, most of the ACE2 receptors, well-known ACE2 receptors, are in the lungs. So they infect the bronchial epithelial cells and type 2 pneumocytes. And that's why you have the most important and most common involvement in this infection is the involvement of lungs or pulmonary involvement. But we already know that ACE2 receptors are not only present in the lungs, but they are also present in the gut. They are also present in the brain, neurons, and endothelium. So a lot of blood vessels, they have ACE2 receptors. And that's why you see a lot of vascular problems, vascular complications related to this COVID infection or corona infections. So it affects the neurons and endothelial cells, not only in the brain, but also systemic blood vessels. So coronary arteries are involved, pulmonary arteries are involved, and intracranial or extracranial cerebral vasculature is involved. So that's probably one of the reasons why it has a multi-system involvement, and it can cause multi-organ damage and multi-organ failure, and it causes a lot of neurological involvement with this corona infection. Now, how does it get to the brain? So most of the time it goes to the brain from the lungs, via spillage from the lungs. It goes to the brain via axonal transport, and then transneuronal spread from olfactory and trigeminal nerves in the nasal epithelium. So this is the direct spread. A lot of times the virus is affects directly to the olfactory bulbs and trigeminal nerve. And this is one reason why a lot of patients who have corona infections, they have basically loss of sensation, loss of smell, and loss of taste because of these two nerve involvements, which are very close to the nasal turbinates. And this virus goes directly to these cranial nerves. And it may be the initial symptom. A lot of times you see patients who have no lungs involvement or no other systemic involvement, but the only thing they have is loss of smell and loss of taste. So that's because of this olfactory and trigeminal nerve involvement. And from that olfactory and trigeminal nerve, it can spread to the other parts of the brain. It can access also via the circumventricular organs, and because they lack a blood-brain barrier, it can go to the brain or nervous system via dorsal root ganglion or autonomic nervous system, which also does not have a blood-brain barrier. One of the major way of infecting the brains and other parts of the body is infection of the endothelial cells. And that's basically called endothelialitis, which is inflammation of the endothelium. Systemic vascular endothelialitis is common in these patients who have primary pulmonary involvement, and in a number of patients who don't have a primary pulmonary involvement, but you can see a lot of endothelialitis. So it promotes vasoconstriction, edema, procoagulant state. So these are all the common complication of this coronavirus, especially in the nervous system. In addition to this involvement, it can cause direct demyelination or damage to the brain parenchyma, it may present like acute disseminated encephalomyelitis. And we have seen that some of the patients who have MS pathology, the scientists have been able to recover coronaviruses from those MS plaques. So it may be responsible for some of the MS patients or demyelinating patients, though we have not seen much of demyelination in this COVID-19 infection. But in previous infection, we have seen patients with demyelinating disease of the brain, which is related to this corona infection. So this slide basically tells you the neurological involvement in the first epidemic. That was SARS epidemic, which is about 20 years ago. And these are the neurological findings which were published 15 years or 20 years ago. Meningoencephalitis was present in those patients. There were large vessel strokes, patients with seizures, and patients with status epilepticus without any involvement of brain parenchyma. So patients without encephalitis and without stroke. they had seizures, and they had the status epilepticus. Axonal peripheral neuropathy was present in those cases. So there was involvement of the peripheral nerves. Olfactory neuropathy was present, and vasculitic neuropathy was present. So these were the peripheral and cranial nerve involvement findings in previous epidemics. Myopathy was common in those patients, and myositis was also common in those patients. And interestingly, some of the studies, they followed those patients from the SARS epidemic for 12 to 36 months. And there is a post-SARS syndrome. Like you have seen patients with post-polio syndrome. You could have symptoms of fatigue and other symptoms lasting for months. And sometimes we have seen patients with dengue infection that post-dengue may remain like 6 months. You have symptoms. So in these patients, they followed these patients for 12 to 36 months. And the post-SARS syndromes was largely fatigue, myalgia, depression. A lot of patients, they have sleep disorders. So sleep was a major problem over a long period of time. And they were able to detect hypothalamic pathology in patients who had post-SARS syndrome. So we learned that this virus goes to the brain and goes to the hypothalamus and causes a lot of hypothalamic problem in the long run. May not be in the short run. So a lot of behavioral and endocrine abnormalities, depression, and largely sleep problems, especially REM sleep disorder was common in those patients who has post-SARS syndrome. And this is something very important because now we have a large number of COVID patients. So this will be important to see that how many of these patients actually develop post-COVID syndrome after 6 months or after 3 months or over like next 1 or 2 or 3 years. So this will be very important. But it appears to me that we have started seeing patients who had COVID infections 2 months ago with some of these symptomatology. So we believe that, in future, we'll be seeing a number of patients who have this post-COVID syndrome like we used to have in post-SARS syndrome. The second epidemic, which was Middle Eastern epidemic, about 1/3 patients had malaise and myalgia. So malaise and myalgia was very common in those patients. A number of patients had demyelination involving brain. So demyelinating lesions in the brain were present, and some patients had acute hemorrhagic necrotizing encephalopathy, which is basically involvement of the brain parenchyma. And this acute hemorrhagic and necrotizing encephalopathy was not reported in the first epidemic, but this is present in the second epidemic. And now we are seeing this hemorrhagic necrotizing encephalopathy in this COVID-19 epidemic. A number of patients had periventricular white matter lesions, and some patients had cerebellum and cervical cord involvement. So this was pretty common in patients who have involvement of the nervous system in the previous infections. And based on these two epidemics and involvement of the neurological system in these two epidemics, it was pretty sure that this third COVID-19 epidemic, it also has a lot of affinity for the nervous system. So we thought that, a large number of patients will have neurological symptoms, and this is what something prompted us to look for the neurological symptoms. And a lot of papers were published in the first 2 months of this epidemic, and now they are being published more and more. So now this in this COVID-19 infection, unfortunately, so the published data is largely Europe and China so far. Maybe the next 2 months we'll have more publications from Asian countries like Pakistan, India, Iran, and now maybe in future we'll have a lot of publications from America, United States, and Brazil, which probably have the largest burden of the disease so far, and it's growing still. So far, the data which I am presenting here is largely European and Chinese data. First, all of the neurological involvement COVID data came from Wuhan, China, and then you have a lot of European studies like from Italy, France, and recently UK. So we have some data from Europe related to neurological involvement. Now, based on those papers, it's about 8 to 34%, depending on what kind of study you look at. So you can say that on average about 10, 15, or 20%, or sometimes 25% patients with COVID-19 infection, they may or they have some kind of neurological involvement. And what kind of neurological involvement? We'll just give you a brief overview of the whole nervous system, that how it affects the neurons and blood vessels of the brain, and what kind of neurological syndromes this COVID-19 can cause, which has been reported in this epidemic. So we started with the central nervous system symptomatology. Headache is common, though not very common. So the study from Wuhan, they reported about 6 to 8% of all patients had headache. The study from Beijing, they reported about 6.5%. Another study from Wuhan, they looked at stroke patients only, and 13% of those, they have headache. So probably maybe 5% or 10% or maybe a little bit more, these patients, they have headache, which may be a presenting symptom of the neurological involvement. Much more common as compared to headache is the agitation and delirium, which is mostly agitation, 69%. But this is the data not from all patients. This is the data from ICU patients. And this is one problem with the data, with the percentage. The denominator changes all the time in these studies. So you will hardly find denominator as all the patients. Most of the time it's ICU patients, it's hospitalized patients to some extent. So that's why the percentage could be varying from few percent to 70, 80%. So this agitation and delirium is only ICU patients data, and 69% patient had agitation, 65% has delirium, and 67% has the pyramidal tracts. And this is just one study from France. Impaired consciousness is an important problem because it is a very important prognostic marker so far from the data which is coming. So patients who have impaired consciousness or low GCS, they have a higher chance of dying. So 22% patients who were fatal basically had impaired consciousness as compared to 1% who were non-fatal. So this is important prognostic marker. But if you look at the data from China, about there was one study showed that 22% patient had impaired consciousness, and the other study showed that 14% patient had impaired consciousness, and it was more in severe cases as compared to non-severe cases. Now, anosmia and hyposmia is basically loss of smell or decreased sense of smell. That was not very high or heavy in Chinese study, and probably one reason is that they were not looking that hard. So a lot of times they did not pay a lot of attention to this symptomatology. Now in European studies, almost all studies, they have put a lot of emphasis on sense of smell. So a lot of data from Europe coming out that, you know, a large number of patients had problem with the smell, and same is true for problem of taste. So in Chinese data, about 5% patients have loss of smell and loss of taste, which is dysgeusia. But in European studies, which is about data from 12 hospitals, 85 to 88% patients have loss of smell and loss of taste. So this is kind of a very important neurological finding in large number of patients who have COVID-19 infection. And this could be the initial symptoms. But the first symptom they develop is this loss of smell, and sometimes that could be the only symptom. That the only symptom from this COVID infection they have is loss of smell and loss of taste, and that's all they have, and they become negative and they recover from the infection. So it could range from like only symptom, it could be initial symptom, or it could be late symptom. We have seen patients who have recovered from this infection, but they have become like a PCR negative, and now they are coming to our clinic with this post-COVID loss of taste and loss of smell, which they did not have while they were infected, you know, or the initial phase or in the middle phase of the disease. So even it could come as a post-COVID phenomenon, or even could late at the of the infection, late end of the infection. So this is something I think important that you should look for this symptom, and it may give you a clue that this patient is developing infection or not. We so far don't know the specificity of these findings, but I think they are important in this kind of pandemic timing, that if someone developed these symptoms, then you should have a suspicion for COVID infection, even if they are afebrile or if they are asymptomatic for other systems. So this is an important finding from these European studies. The other one, which is other symptoms which are very common and very important, is stroke. So stroke is one of the most prominent feature of this COVID-19 infection. It can range from like 2% to 20%, depending on which study you look at and which patient population you look at. So from Wuhan, China, it was about 2.4%, which is they have all 214 patients in one study, and out of that, 6 patients developed a stroke. 5 of them were ischemic stroke and 1 was hemorrhagic stroke. Another study from Wuhan, China, they have 221 patients altogether in one hospital, and 13 of them developed stroke. So that was like 5.8%. And large vessel stroke was 11%, hemorrhagic stroke was 1 patient, and cerebral venous sinus thrombosis was 1. So if you look at 6 case series from China, so there was a pooled analysis which showed that about up to 6% patients may develop a stroke in this patient population. Now, the study from France, they only looked at ICU patients. So in ICU patients, there were about 20% patient had stroke, and large vessel stroke were also reported from New York. They were mostly case reports. So these stroke is a very important problem. It could be arterial, it could be venous, or it could be hemorrhagic stroke in these patients. There was one article which have shown that patients with the COVID infection, they have frontotemporal hypoperfusion. They have looked at the cerebral blood flow through the functional MRI, and they have shown that, almost all patients which they looked, they have frontotemporal hypoperfusion. And this frontotemporal hypoperfusion basically means involvement of frontal lobe, and that usually means behavioral symptoms and a lot of cognitive problems with this infection or maybe in the future. So this is something maybe very important in future, that how many of these patients, they develop cognitive deficits after the infection is over, especially if they have involvement of the frontotemporal lobes. And these are the patients who do not have frontotemporal abnormalities on MRI or frontotemporal, other signs of frontotemporal involvement. So this is important. This is a very important biomarker, hypoperfusion of that part of the brain. Arterial and venous thrombosis is very common. As we discussed, this endothelial dysfunction is a common problem. And not only endothelial dysfunction, but the coagulation system dysfunction is also a problem, which may be related to this ACE2 receptor or maybe related to endothelialitis. So we don't know for sure that how it causes hypercoagulable states, but there's a lot of association with anticardiolipin antibodies and anti-beta-2 glycoprotein antibodies. So these are the antibodies which may be related to this venous thromboembolism. But this is a very important area, an important area to be studied in future, that how it causes coagulation abnormalities. Some patients have presented with DIC and others kind of coagulopathies in these patients. So this is there are a few data sets, one from Netherlands, which have looked at 184 patients from 3 hospitals, and they showed that 31% patients had thrombotic complications, including pulmonary embolism. 27% patients had venous thrombosis, 3.7% has arterial thrombosis. There were multiple arterial thrombosis in legs, hands, and brain, and these patients had anticardiolipin antibodies and anti-glycoprotein antibodies. There were patients who had multi-organ failure, and that is mostly related to endothelial dysfunction or lymphocytic endothelialitis and endothelial involvement of the system. So that is probably responsible for arterial and venous thromboembolism in these patients. Subarachnoid hemorrhage was present in 1 patient that was reported from France, and this patient has ITP, so it was immune thrombocytopenic purpura. Acute hemorrhagic necrotizing encephalopathy, not very heavily reported, only few case reports, but that hemorrhagic encephalopathy was also reported in the MERS infection. So it's probably the same mechanism. Meningoencephalitis is not uncommon. Even we have a few patients who have meningoencephalitis. The first case was reported from Japan related to COVID-19, and this patient has seizure, neck rigidity, and CSF pleocytosis, and the CSF PCR was positive for SARS-CoV-2. So you could have patient presenting with meningoencephalitis. Encephalopathy is very common. Encephalopathy means these patients, they do not have any direct involvement of the brain. So CT or MRI is normal, CSF is normal, but they have diffuse encephalopathy, like we commonly see in patients who have urosepsis or septic encephalopathy. So that kind of encephalopathy is not uncommon in these patients. And these patients present with confusion, myalgia. Sometimes they have meningeal signs. They may have CSF, high increased intracranial pressure. But usually, with these patients, they have normal CT scan or MRI. So we have some patients who have septic encephalopathy-like features without any evidence of sepsis. So that's probably one of the presenting feature of COVID, that they present with encephalopathy. Seizures are also well reported. You could have patients with single seizure, multiple seizure, or there are few case reports of status epilepticus. And these are the patients who do not have any primary brain involvement. So these patients, CT and MRI is normal, CSF is normal, and they have seizures. So it means there is an involvement of the brain parenchyma, which you cannot pick on CT, MRI, or abnormality on CSF. So there is involvement of the neuron or parenchyma, which present as seizures. So seizures are not uncommon. And if someone develops seizures in these patients, we should be looking for brain abnormalities, or we should be doing CT, MRI, and CSF to look for brain abnormalities. But if you are unable to find, then you still treat them with the anti-epileptic medications, and most of the time seizures are pretty well controlled. Another feature of this infection is not only involvement of the brain parenchyma, but also involvement of the spinal cord. So myelitis was reported. There's only a few case reports related to COVID myelitis, but these patients, they have pneumonia and present with acute flaccid paraplegia. And if someone develops symptoms of myelitis, COVID should be looked at. It could be immune-mediated myelitis, like we see in transverse myelitis or post-infectious myelitis, but it could be a direct infectious myelitis. And in virus, virus is direct. It's a neurotropic virus, so it can cause inflammation of the brain parenchyma, inflammation of the spinal cord. So it may cause direct myelitis, this virus, and that's reported from Wuhan, China. The other parts of the nervous system is in the peripheral nervous system. So neuritic pain is very common, 8.9% in China, and more series will be looking in future about the peripheral nervous system involvement. Now, interestingly, there were some case reports of GBS related to COVID-19 infection. And, in one case, it was like the first manifestation of this COVID-19 infection, that they developed a peripheral nervous system involvement, and then they developed involvement of the central nervous system. So there were only few case reports, maybe like 4, 5, or 6 case reports of GBS related to COVID-19 infection, China, USA, and Italy. And they're all patients who have COVID, except one who had developed GBS first and then developed COVID. The other patients who had COVID, and during the course they developed this GBS, which is Guillain-Barré syndrome, which is basically demyelinating neuropathy of the peripheral nervous system. You could have involvement of the brain cranial nerves in the Miller-Fisher syndrome. Miller-Fisher syndrome is basically cranial neuropathy present with external ophthalmoplegia, ataxia, and areflexia. These patients present with diplopia. So Miller-Fisher syndrome is a cranial neuropathy. It was reported in one patient. Multiple cranial abnormalities were present in one patient, and neurosensory hearing loss was also present, published in one case report. So you could have involvement of the cranial nerves with this infection, which could be probably direct injury to the nerve or invasion of the nerve by virus directly. Another very important area of involvement in this COVID infection is muscles. A lot of patients, they have muscle findings, subjective and objective both. So about in Chinese study, 36% patient had early symptoms of muscle involvement in about 1,200 patients. 26 to 51% patient had muscle fatigue. So myalgia, which is a very common feature of viral infection, is not uncommon, and it can persist for months sometimes. 26 to 51% patient has muscle fatigue. Myopathies were present in 10% patients. Myopathies could be a critical illness myopathy, or could be an infectious or metabolic myopathy. So there were inflammatory myopathies, and these are detected by doing EMGs. It's not uncommon to have inflammatory myopathy in patients who have COVID infection. We are still not sure that how this virus causes myopathy. Does it cause direct myositis or inflammation of the muscle, or it's infiltration from the blood vessels to the muscle? But it's common involvement. Rhabdomyolysis is also common. 33% patient has increased CPK levels in Chinese study, and there were early signs in 2 case reports. So rhabdomyolysis showing as CPK, and these are the things I think we should look for if these patients have muscle symptoms. Is look at their CPK levels, look at their nerve EMG studies if they have inflammatory myopathy and myositis. So muscle involvement is important for symptomatic treatment and for the long-term care of these patients, and sometimes for the disease progression, look for the disease progression. Now, another very important feature of COVID-19 infection is direct involvement of the brainstem and respiratory failure, which is exclusive of the lung involvement. So there are many case reports of patients who develop neurogenic respiratory failure due to viral brainstem invasion, and these patients did not have much lung involvement. So lungs were pretty clear or not that severely affected, but these patients developed respiratory failure, and it is suspected that this was pure neurogenic respiratory failure. So neurogenic respiratory failure is not uncommon in patients, and it may be a confounding feature. Like patients who have lung involvement, they may also have brain stem involvement, and it may be a defining feature in those patients, because it is suspected that those patients who have poor prognosis or who were unable to survive without patients without a huge lung disease, they could be due to neurogenic respiratory failure. So it's not uncommon in patients who have COVID-19 infections to have neurogenic respiratory failure, or a combination of lung failure with neurogenic respiratory failure, which may translate into increased mortality and poor outcome of these patients. So this is an important feature of this COVID infection and part of the neurological involvement of this COVID-19 infections. Now, there are many isolated reports other than these involvements. So there are few isolated reports of myelitis. There are reports of myasthenia gravis exacerbation. So far, there is no report of myasthenia gravis related to COVID infection. But a large number of myasthenia gravis patients, they are on immune suppressant medications, and they're kind of more prone to develop COVID infection. And the COVID infection has been well reported in patients who have myasthenia gravis. And there were a few reports that these patients developed a worsening of the myasthenia gravis. It could be related to their medications, because sometimes doctors tend to stop immune suppressant medications if they become COVID-19 positive. So this is an area which has to be looked at, that if you should stop immune suppressant medication in these patients or not. But there was myasthenia gravis exacerbation. Cerebral venous thrombosis is now well reported. We have a patient with CVT at our hospital related to COVID-19 infection, and neurogenic respiratory failure is also very well reported in case reports. And these are the patients who have pretty much normal lungs or without any pulmonary involvement, but they still had respiratory failure. Status epilepticus is also well reported, and demyelination is also reported with this COVID-19 infections. Only few case reports, patients present with AGEM or periventricular lesions, but this is has been well reported in patients with the COVID-19 infections. Now, in neuroimaging is important to identify the kind of brain involvement in these patients. So I have included a series of patients who had brain imaging. So this is a series of 749 patients, out of which 27 patients had MRI of the brain. And these patients who had neurological symptoms, so all of these patients, they had neurological symptoms. And about 44% of these MRI were abnormal. Our most common abnormality which we have seen in those MRIs is called flare signal abnormality. It could be a hyperintense lesion involving the cortex of the brain, subcortex, or deep white matter. Other abnormalities which have been reported as infarction, which could be a large vessel infarct or a small vessel or watershed infarct, cerebral venous thrombosis, and leptomeningeal enhancement. So these are the findings which were reported in this series of 27 MRIs, and hopefully there will be more coming in future with more widespread involvement of the nervous system. So this is, for example, a patient who had this MRI. This is flare MRI, which you can see that these are the hyperintense abnormalities in the deep white matter region. This is the white matter region, and this is also involvement of the cortical region. So this is a cortical flare abnormality. This is a T1 weighted image with it, which is non-contrast. This is a contrast image, and you can see very fine contrast enhancement in some parts of the brain, especially in the frontal lobe. And these are also gradient echo and flare images showing involvement of the frontal lobe. So mostly frontal lobe involvement, cortical involvement, and deep white matter involvement. This is common in these some of these patients, and especially in this patient. This is another patient with COVID infection, and a lot of these patients, they may not have clear-cut neurological findings. They may have some cognitive deficits and some encephalopathy, but not a lot of focal neurological deficit. But this is again a T2 a flare MRI showing hyperintense signal in this periventricular region. This is also periventricular white matter changes. This is a T1 without contrast, and this is the T1 post contrast. And you can see that there is some, fine contrast enhancement in this frontal lobe. So very few specks of contrast enhancement or contrast enhancing lesions in this part of the brain. This is again showing cortical signal abnormalities. This is cortical and subcortical both. You can see the whole right MCA region is a little bit hyperintense, and that is probably suggestive of ischemia in that part of the brain. So this is another patient. Another patient with only frontal lobe abnormality. So this is a cortical flare signal abnormality in the frontal lobes, bilateral frontal lobes. This is a T1 post contrast showing some enhancement in the frontal lobes, not much in the deep white matter, some hyperintense lesions in the deep white matter. So this is the kind of signal abnormalities which we find in number of patients who have COVID infections, who have primary brain involvement or who do not have any, some of time, a lot of neurological findings. This is again a flare image showing hyperintense lesion involving the occipital lobe and the periventricular region and in the frontal lobes of the brain. So this is how it presents, and these are the findings you should look for in patients who have this kind of infection. The other area which has been looked at recently is the neuropathology of these patients, that how many patients have involvement of the brain and what kind of involvement of the brain they have. So this is one study which has shown the early post-mortem findings, and most of these patients did not have frank neurological involvement on the neurological examination, and even did not have a lot of abnormalities on MRIs of the brain. But once we look at the patients who died of pulmonary pathology in patients who had COVID infection, we were able to find a lot of intracranial pathology in those patients who did not have a neurological findings. So intracranial vasculopathy was common. Asymmetric olfactory bulb was a very common finding in some of these patients. Subcortical micro and macro bleeds were present, which were posterior predominant. There were multifocal hemorrhagic lesions. Posterior reversible encephalopathy syndrome is a radiological entity, but findings which are present in press or posterior radiological and posterior reversible encephalopathy, they were present in postmortem findings of these patients. And infarction was present in the especially deep watershed infarctions, and endothelial inflammation was present. So this is the neuropathology of patients who have COVID infections and who died of primarily lung disease or primarily multi-organ failure. So this is a spectrum of the neuropathological findings which we could find in these patients. And these are some of these lesions. They were kind of asymptomatic, and patients did not have a lot of neurological findings based on all those symptoms. This is some of the papers which our group published. We published this paper in Lancet Neurology in February. We picked that a large number of these patients have neurological involvement. So World Federation of Neurology, and this patient paper was written by World Federation of Neurology team group of people. We suggested that we should develop international neurological registries across the globe for patients who have neurological involvement, to learn the neurological involvement and the extent of nervous system involvement in these patients. That was published like in April, and that online published in April. So this paper we published submitted in March. So from since March, our group is working on international neurological registries. This is also a paper published in Journal of Neurological Sciences, which is a very extensive review of this topic. And this is also a paper which became basis for the international neurological registries. So now there are COVID neurology registries going on in about 30 countries, and we are collaborating with all those countries. Now, hopefully, we'll be able to start one in Pakistan too. So this is an important, and hopefully we'll be able to get data of about 20,000 to 50,000 patients who have neurological involvement across the globe, and we'll be able to look at all those patients and their symptoms and their findings, and hopefully that will translate to a lot of knowledge related to this infection. This is another study which we started in May, which is stroke and SARS-CoV-2 infection, which is called Cascade. This is also a global registry of stroke in patients with COVID-19 infections. And so far, we have been able to recruit about 100 plus patients with stroke related to COVID infection. Our target is more than 1,000 patients. So hopefully that will be in next 3, 4, 5 months. We'll be able to recruit a large number of stroke patients from across the globe. We have a stroke COVID CVT registry, which is going on, and hopefully we will be able to recruit some patients for that. This is a paper which we published in JPMA. JPMA published a whole issue on COVID infection. So this is a neurology part of it. This is we published an editorial in our Pakistan Journal of Neurological Sciences, and that was one of the early papers related to this infection, which we suggested that a large number of these patients they have a pure neurological involvement, and this neurological involvement could be identified by loss of taste, smell, and presence of neurogenic respiratory failure. Dr. Dureshawar published 2 papers related to this COVID-19 infection, one in PJNS and one in JPMA. So a lot of future research work in progress related to COVID-19 infection. Our residents and our team has already in process of publishing an article on transformation of neurological care in COVID patients. And this is a very important area. And I think this has to be documented, because this will be a very important information for the future generation, that how did we handle in terms of care, providing care in this pandemic area. So I think this has to be written and documented for the future care. Maybe if there are upcoming epidemics, I think that would be a very good learning experience. So this is a paper coming out which will educate the whole community, that how you just transform the whole care from outpatient care to training to inpatient care to specialized care, ICU care, when you have these kind of pandemics. So this is basically a practical approach on how to change the care. We are conducting a national survey for COVID preparedness and impact. We have recruited so far 20 centers across the country, and our target is 40 centers. So hopefully, this will be a very informative paper. We are in process of starting a AKU COVID neurology registry. At AKU, we have admitted so far 800 plus patients with COVID, and I believe that about 10, 15, 20% patients of those, they would probably have neurological involvement. So we will be looking at all those patients, and our target is to review more than 1,000 patients with COVID at AKU and look for the neurological findings and symptomatology and whatever the investigations were done. We are already part of a COVID stroke and CVT registry. So far we have only few patients with a stroke or CVT related to COVID infections. But maybe if now we are looking more and more, so hopefully we will be able to find more patients. We are working on a national COVID neurology registry. As soon as our AKU registry is approved by the ethical review committee, we are going to get a national bioethics commission for a national COVID neurology registry. We have talked to some of our colleagues in other centers in the country, so they are willing to participate. And our target is to get maybe 500 patients or more with the neurological involvement in COVID patients, and hopefully that would be a very important database of patients who have neurological involvement in COVID infections. And this another area which we are, I think, going to look is the long-term neuropsychiatric impact of COVID-19 infections. This so far this has not been started. So hopefully, if we are able to start, we will be the initial people to publish the data, that we should follow these patients for at least number of months, and to see that, you know, how does this infection affects the brain and behavior of a patient who was infected. And that is something which we are going to find out over a period of time. So hopefully we'll be able to look at a number of these patients as a long-term care patients to see that what are the neuropsychiatric impact of this COVID infection. So hopefully this information which we are collecting and which other people are collecting, we believe that we are going to learn a lot from. This is a big challenge, this infection, for the whole humanity and for the medical community. But hopefully this infection has taught us a lot of things already. And hopefully we will be able to learn a lot of things from this infection in future. And hopefully that will lead to improved understanding of the brain and the virus and immune system and vascular function. And hopefully that will translate into better care and improved care of these patients in future, and maybe prevention of these complications in future related to this infection. So at the end, I would like to thank all the participants for listening, and I will be glad to answer any questions if there are any. Thank you.
Thank you, sir. Thank you, sir. It was very comprehensive talk regarding the COVID involvement of neurological involvement of COVID. So the forum is open for question and answer.
Our failure many times.
Dr. Javed has a question for you.
Sure, sir.
हाँ वासे भाई अस्सलाम वालेकुम माशाल्लाह काफ़ी डिटेल्ड टॉक था आपका। बात यह है कि कोविड-19 जब से आया है, एवरी स्पेशलिटी ट्राई टू पोर्ट्रे कि हमारा जो है सिस्टम है, इट इज़ मोर इम्पोर्टेंट इन कोविड-19। बात यह है कि आपने बहुत सारे ऐसे सिम्टम्स बताए, जैसे नॉस्मिया है, हेडेक है, क्या कहते हैं मसल एक है, ये तो मतलब कॉमन फॉर एनी वायरल इन्फेक्शन। मेरा सवाल ये है कि फॉर एग्जांपल आपने कहा 2 to 5% स्ट्रोक पेशेंट आया, तो बात ये है कि स्ट्रोक तो वैसे ही कम्युनिटी में बहुत कॉमन है। अगर कोई पेशेंट स्ट्रोक के साथ विद कोविड पॉजिटिव आता है, तो हाउ कैन यू से दैट इट वाज अ कोविड इन्फेक्शन व्हिच लेड टू द स्ट्रोक? व्हाई कांट इट बी जस्ट एसोसिएशन, बिकॉज इट इज सो कॉमन इन द कम्युनिटी? Similarly, there are other diseases that you mentioned, 1% of myasthenia, 1% of this, 2% of this. I mean, these are all very common things that any neurologist see in the usual medical ward. Can you answer this, please?
Sure, sure. There are two things. Number one, none of the viral infections have been reported so far to have 70-80% patient with anosmia or hyposmia. So sense of smell may be present in some of the viral infections, but so far no systemic viral infection has been reported to have that extent or that spectrum of smell abnormalities or taste abnormality. That's one thing. Number two, for stroke patients, you have to look that if those patients if they were like stroke prone patient, for example, someone who is diabetic, hypertensive, atrial fibrillation, and they develop a stroke, then these are probably related to the conventional risk factors. If you have patients who do not have conventional stroke risk factors, and if they present with stroke symptomatology in an infectious area, and you see abnormalities of the intracranial blood vessels, which you are not supposed to see in those patients. So these are the subjects you suspect that this infection, this stroke is related to this infection. So most of these stroke patients who have developed these stroke are patients who developed stroke because of this infection, not because of primary problems. So for example, a lot of studies, they've excluded patients who have atrial fibrillation. So if you have atrial fibrillation and had a stroke during or after COVID infection, that they have not included those patients in those stroke registry of those cases of COVID infection. So that's also an exclusion criteria for us, that if you have a stroke prone condition, then you cannot blame COVID infection for that infection. So that kind of that's the kind of data which we are looking for, patients who develop stroke who do not have a large many conventional risk factors or atrial fibrillation or other factors and develop a stroke, and you see a lot of intracranial abnormalities of the blood vessels with that stroke. So these are probably patients who have COVID-19 and stroke.
Sir, there is a student who is asking about the duration of anti-epileptics in those patients who had seizure after having COVID infection.
Usually in patients who have provoked seizures because of any of the conditions, if they do not have any brain involvement, it means that they did not have encephalitis or they have pretty normal brain MRI. We usually give them anti-epileptic medications for 3 to 6 months, and then we try to stop. Now, if they have infarction or if they have a lesion in the brain, then probably they need anti-epileptic medication for longer period of time. But most of the time, if the MRI is normal and there was no meningoencephalitis, only seizure, 1 or 2 seizures, anti-epileptic medication for 3 to 6 months is enough. If they have status epilepticus, probably they are going to require anti-epileptic medication for longer period, maybe 6 months to or 12 months. But normal MRIs and no condition which can cause persistent or recurrent seizures, they do not require long-term anti-epileptics.
Dr. Abu Bakr Sheikh have a question for you.
Sure. Ji, sir.
Yeah, Wasay, excellent exposition of developing syndrome. I have 2 questions. One is, why is not neurologic involvement more commonly seen, as brain is highly hypoxia sensitive? And as you know, this disease, COVID-19, has a prominent feature of intense hypoxia. The second question is, should MRI be done in COVID patients who have impaired consciousness as part of the presentation?
Well, if there are 2 things. Number one, we have not seen much hypoxia in patients, probably because hypoxia is present in COVID patients, especially with lung involvement, but all of them they are treated. So they are treated with the oxygen or ventilation. So we don't see much hypoxia in patients of COVID-19 infections. Now, as far as the MRI is concerned, so far the recommendation to do MRI is only for those patients who have neurological involvement or neurological findings. For research purposes, it could be done, but that needs like an ethical approval and funding to get it done. But for practical purposes, it's not recommended to do MRI or brain scan in every patient who have encephalopathy, unless they have a focal neurological deficit, or unless you are unable to identify a cause of encephalopathy. For example, if there is already sepsis and there is already so many reasons to have encephalopathy, then unless it's clinically indicated, we do not recommend to do MRIs in every single patient. But it can be done for research, and there are few studies now going on which are looking at all patients who have COVID-19 infections, and by doing brain MRIs in Europe and USA. That data is not out yet, so hopefully that will inform us that patients who have no symptoms or mild symptoms related to neurological involvement, what kind of MRI abnormalities they have. But in AKU and in Pakistan, we are only doing MRIs and scan for those who are clinically indicated.
Maybe, Wasay, I could point out that the main feature of COVID-19 is hypoxia, that patients go on vent, high PEEP, high flow oxygen, and even ECMO is considered to improve oxygenation. So oxygenation is definitely one of the main features of this disease. Maybe it's not seen so much in neurologic practice, but in other areas like in pulmonology and intensivist care, hypoxia is extremely important. Maybe one needs to look at it further.
Okay.
So Dr. Zegam has a question for you.
Sure.
Nice presentation, Wasay. I just want to know, do we do CSF just to find out the presence of COVID virus PCR positivity in those patients who have encephalitis or encephalopathy? And do we perform this as a procedure?
We are not doing it at AKU. We are not doing it at AKU. We could do it. Like at this moment, we are not doing it. Like not in Pakistan, but other centers they are doing like because we are doing COVID with the swab only at this point, the PCR. But we could do you could use almost any body fluid to look at this virus, and you could do PCR from any sample. So far,
because yeah, this came into my mind because
we have to talk to the lab if we want to do it. But I think they could do it. I don't see any problem doing it. Yeah, we have not.
Because if you want to, if you want to correlate in a scientific way that your patient with stroke or encephalitis, encephalomyelitis, they are related to this COVID virus, then this would be a good choice to have this documented also.
Exactly. We are not doing a lot of LPs in patients who have this COVID and symptoms, unless we are suspecting encephalitis or meningitis. So that's probably why it did not come up that we should do a CSF PCR, though I don't see any problem in doing CSF PCR for COVID. But probably if we want to do it, we have to talk to the lab. I think we should consider if patient we are suspecting neurological involvement, we should be able to do a COVID PCR in CSF samples. I don't see any problem.
So is there anyone else who want to ask anything?
I just want, this is Zainab. Thank you, Dr. Wasay. That was a brilliant grand round, and I really learned a lot today.
Thank you.
So I think there are no more questions. Thank you, sir. It was very comprehensive talk.
Thank you all.
Thank you, everybody.
Thank you for listening.
Anyway, thank you.